Good day, everyone. I'm Dr. Jerald Lim, a CTMR Imaging Fellow, and I'm here today to discuss about critical findings in the chest. I have no relevant disclosures pertaining to this talk. My objectives are to define critical results and to enumerate select critical findings in the chest, with emphasis on radiographs and cross-sectional imaging. So critical result is defined as any result or finding that may be considered life-threatening or that could result in severe morbidity and require urgent or emergent clinical attention. Each facility has leeway to define its own critical tests and results, and thus there is really no standard list for either category. But what is essential is that it requires rapid communication of results, whether normal or abnormal. So now we tackle the critical findings in the chest. First one is pneumothorax. It's basically air within the pleural space and is most commonly from rupture of subpleural blebs. As you can see, the tiny lucencies at the periphery of the collapsed lung. It most commonly occurs in 20 to 40-year-old males who are asthenic and are smokers, and is characterized by acute onset of pleuritic chest pain, dyspnea, or back or shoulder pain. On chest radiograph, in an upright position, these are the radiologic signs. You will see an area of lucency with no pulmonary markings. It's pointed by the white arrows. And these represent the air in the pleural space. The yellow arrows, meanwhile, point to a thin white visceral pleural line associated with lung collapse, which is the single best sign for pneumothorax. The red arrow points to a depressed left hemidiaphragm. And these are the classic findings, and this is easy to identify, especially when the pneumothorax is massive. But what if the patient is in a supine position? Will you still see these classic signs? Well, yes, especially when the amount of pneumothorax is moderate or large. The problem is when it's minimal, and the picture may look differently. So in a supine position, air may go to different spaces. So if the patient is lying down, the air will go to the anteromedial portion, and this is the earliest location. So the pneumothorax may not display the classical signs. Instead, the pneumothorax may be demonstrated by looking for the following signs, namely the outline of the medial diaphragm under the cardiac silhouette and the deep sulcus sign. This is a pneumothorax in the infrahilar anteromedial space due to vehicular trauma. You see in the supine radiograph, there's a sharp delineation of the left heart border and the deep anterior cardiophrenic sulcus, while the corresponding axial CT of the lung base shows substantial air collection in the pleural cavity at the anterior cardiophrenic sulcus. In a supine patient, air may also outline the anterior portions of the hemidiaphragm and cause visualization of the anterior costophrenic sulcus, when both the diaphragmatic dome, which is outlined by the white arrow, and anterior portions of the diaphragm outlined by the pleural air, as depicted by the black arrow. If both of these are visualized, the double diaphragm sign is produced. The second most common location is at the subpulmonic space, as in this case of a middle-aged woman with interstitial pneumonia. Supine radiograph shows a hyperlucent upper quadrant of the right abdomen, and corresponding coronal CT image clearly depicts the inferior surface of the lung, a sharply outlined diaphragm, and IVC, and the deep sulcus sign as well. This pneumothorax, meanwhile, is in the posterior medial space of an elderly man with chronic obstructive pulmonary disease. A supine radiograph shows a lucent triangle with a partially collapsed left lower lobe. Corresponding CT image of the lung base shows pneumothorax in the posterior medial space, and the left inferior pulmonary ligament, which is the linear structure between the mediastinum and the left lower lobe, is clearly visible. This is a pneumothorax in the apicolateral space of an elderly male due to esophageal perforation caused by endoscopy, which resulted in pneumomediastinum, pneumothorax, and subcutaneous emphysema. This is a supine radiograph with corresponding coronal CT images showing the visceral pleural line in the apicolateral space, the pneumothorax in the intermedial space and subpulmonary space, pneumomediastinum, and subcutaneous emphysema are also visible. There are no vascular markings that exist beyond the visceral pleural line. However, there are potential mimics for pneumothorax, so you have to be careful, and here are some examples. This is an elderly male with sepsis. You can see that there is a linear opacity nearly parallel to the right chest wall extending from base to the apex. Here's a closer view. The lung marks are evident, peripheral to this line, implying that this is not air in the pleural space. This is actually a skin fold. Skin fold is usually mistaken as visceral pleural line, and they typically occur in the elderly with loose skin. And to differentiate the skin fold and pneumothorax, absence of increased lucency laterally and demonstration of lung markings across a curvilinear shadow likely represents skin fold. Now in this image, it is focused on the left upper chest and you can see a white line shown by the arrows. Could this be a visceral pleural line? The answer is no. This is the edge of the scapula, and you can easily follow the contour of the scapula to make sure it does not project over the chest. In this image, there's an area of lucency in the right upper lobe that is devoid of pulmonary vascular markings. This looks just like a pneumothorax. There is also a white linear opacity shown by the yellow arrow that looks like a pleural line. This is actually bullous emphysema. Distinguishing pneumothorax from bullous emphysema can be difficult, but it is important to distinguish them since management may vary. Now in a tension pneumothorax, air from a ruptured lung enters the pleural cavity without means of escape, and as air pressure builds up, the affected lung is compressed and all of the mediastinal tissues are displaced to the opposite side of the chest. In cases where classic features are not clearly present, a number of techniques can be employed, such as the lateral decubitus radiograph. It should be done with suspected side up. The lung will then fall away from the chest. So if the suspected pneumothorax is on the right chest should be up. That is the left lateral decubitus position. Inspiratory and expiratory projections are one technique that can be used to make a pneumothorax more obvious. In expiratory chest radiograph, the lung becomes smaller and denser, and the pneumothorax remains the same, thus making the pneumothorax easier to identify. But if it is impossible to identify in radiograph, then we should still request for a CT. Pneumomediastinum is the presence of extraluminal gas within the mediastinum. Gas may originate from the lungs, trachea, bronchi, esophagus, and peritoneal cavity and track from the mediastinum to the neck or abdomen. It commonly results from blunt or penetrating chest trauma, or maybe secondary to neck, thoracic, or retroperitoneal surgery, or even perforation of the esophagus or trachea. These are chest radiographs, PI lateral views. You see the blue arrow points to a linear lucency under the mediastinum, and it is continuous from right to the left hemidiaphragm. This is the continuous diaphragm sign. The red arrow, meanwhile, points to a lucency at the inferior cardiac border. This AP radiograph demonstrates pneumomediastinum outlining the left subclavian artery and possibly the left carotid artery, and is called as the tubular artery sign. Another lateral radiograph demonstrates the ring around the artery sign, which is seen on lateral chest radiographs as a well-defined lucency along or surrounding the right pulmonary artery. The Nuclearia V sign is a sign described on the plain film in patients with pneumomediastinum occurring often secondary to esophageal rupture. It is seen as a V-shaped air collection with one limb outlining the left lateral mediastinal border, while the other limb between the parietal pleura and left hemidiaphragm. The Spinnaker sign is a sign of pneumomediastinum seen on neonatal chest radiographs. It refers to the thymus being outlined by air, with each lobe displaced laterally and appearing like spinnaker sails. It is distinct from the sail sign appearance of a normal thymus. So can you identify the critical finding in this radiograph? Okay, so the ET tube is too low. The tip of the endotracheal tube is in the right main stem bronchus. So this is a critical finding, and you need to relay this right away because right main stem bronchus intubation will lead to atelectasis of the entire left lung and hyperinflation of the right lung. Most often, endotracheal tubes are malpositioned in the right main stem bronchus because of the shallower angle of the right main bronchus makes the trachea than does the left main stem bronchus. Here's another radiograph showing a malpositioned ET tube. In this case, the tip is at the bronchus intermedius, and this is much lower compared to what I showed you a while ago. Bronchus intermedius intubation may lead to atelectasis of the entire left lung in the right upper lobe. Here's another malpositioned tube. A linear opacity seen coursing the midline, and it made a loop going up, and tip is seen at the level of T2. This is a malpositioned feeding tube. In this radiograph, the feeding tube is not inserted to the adequate length, so further advancement of the NGT is needed for this patient. The ideal position should be in the subdiaphragmatic position, identified on a plain chest radiograph as overlying the gastric bubble. Ideally, it should be at least 10 centimeters beyond the GE junction. Here you have a chest PA view with a large rounded opacity or focal bulge with rim calcification at the region of the aortic knob. This finding is highly suggestive of an aortic aneurysm. Although without the vascular calcification, this may also suggest a superior mediastinal mass. A thoracic aortic aneurysm is the ballooning of the upper aspect of the aorta, which is above the diaphragm. And the term aneurysm is used when the axial diameter of the thoracic aorta reaches or exceeds 5 centimeters. On chest radiograph, the most common finding of aortic aneurysm is not really focal bulge, but just widening of the mediastinal silhouette, enlargement of the aortic knob, and tracheal displacement. In aneurysms may be complicated by dissection. Aortic dissection is the most common form of acute aortic syndrome. It occurs when the blood enters the medial layer through a tear in the intima and tracks along the media, form a second blood-filled channel within the wall. And patients may present with anterior or posterior chest pain and a tearing sensation in the chest. And CT angiography has a reported sensitivity and specificity of nearly 100%, so it has to be done in patients with suspected aneurysm and dissection. Complications include abdominal organ ischemia or embolic stroke. And in some cases of aortic rupture, especially those involving the ascending aorta, the involvement of the coronary arteries may result in infarct or occlusion, so it may be warranted to do dedicated CT of the coronary arteries in this case. It is also imperative to do 3D reconstruction, as shown here. So let me show you another critical finding more often found in young children. This blue arrow points to an opacity. Actually, this is a foreign body, an earring to be specific, which is lodged in the right main stem bronchus of a 25-year-old. Again, the right main stem bronchus is a common location due to its posterior location, shallower angle to the trachea, and wide diameter. With non-radio-opaque foreign bodies, indirect signs of aspiration will include focal overinflation or atelectasis. Another critical finding is severe narrowing of the airway, like in this case resulting from a large lobulated thyroid mass. Lastly, pulmonary embolism refers to embolic occlusion of the pulmonary arterial system. The majority of cases result from thrombotic occlusion such as DVT or deep vein thrombosis, which are usually coming from the lower limbs. And these are depicted as filling defects within the pulmonary arteries in a patient with dyspnea, chest pain, and even hemoptysis. So you have gone through the most common and important critical findings in the chest, which we cannot miss during our duties and should warrant rapid communication with the radiologist or clinician in order to add value in patient care. These are my references. Thank you very much for your attention. I hope you learned something today.